over today, we're getting a late start, but only by about 10 minutes. So at 5:40, let's call the meeting to order. In compliance with the California Brown Act, the District Board of Directors welcomes comments from the public. This is the opportunity for members of the public to directly address the District Board of Directors on any item of interest to the public under the jurisdiction of the district, including items on tonight's agenda. Persons wishing to make a presentation to the board shall occur the following: a written request to the board on the form provided at the meeting, which is optional. Oral presentations are limited to 3 minutes, and any member of the public will be afforded the opportunity to speak at the beginning of the public meeting. During the general public comment section of the agenda on any item under the jurisdiction of the district, as well as during the consideration of an individual item on the agenda for that public meeting. However, the 3-minute time limit described will be applied to an individual's cumulative comments during the meeting. Proceeding the board are part of the public record, and materials related to an item on this agenda submitted to the Oak Valley Hospital District after distribution of the agenda packet are available for public inspection in the Secretary's office, which we need to change this address. Yeah. Okay, which is in the old hospital, actually in the OB suite, so we're going to have to figure out how to describe that. Okay, getting right down to it, we have an action item, which is our consent calendar, which is comprised of actually 2 items tonight, because we don't have any administrative forms and policies, but we do have Oakdale Nursing and Rehab Center report by Will Pringle. He usually gives us his report verbally, but he is not with us tonight due to outstanding issues. And we have the approval of July 3rd, 2025 meeting. Has everybody had the opportunity to read the Oakdale Nursing and Rehab Center report and the minutes of our last regular meeting?
Make a motion to approve both consent calendar items, Oakdale Nursing Rehabilitation Center report, and approve of the minutes for July 3rd, 2025.
I second.
Okay, I have a motion to approve by Dr. Trot, seconded by Sarah Shipman, Director Shipman. All in favor?
Aye.
Okay, it's passed. Medical staff report. Dr. Coon.
Okay, so medical executive committee met on July 15th, and we approved the following items. We approved the Department of Medicine committee report and approved the different policies and forms. So there was several updates: administrative manual, clinical manuals, such as alcohol withdrawal and rapid response team, clinical pharmacy manual, and infection control manual, as well as the pharmacy manual Pyxis medication station. And we approved all of those items. Additionally, we were asked to approve the appointment of our safety officer, Don Peterson, and infection preventionist, Patty Barcelo, which we approved. And then finally, there were some other forms and policies we looked over, and the clinical manual we approved, as well as we approved retirement and updates on environmental sciences and infection control manuals. And then finally, there was a dosage chart, Oak Valley Hospital emergency medications dosage chart, which we approved. So that completes my items that we went over in the last medical executive committee.
Quite busy this one. Okay, this is an action item. If any of the board members would like to take any one of these items and as its own to describe, or I will entertain a motion to accept all.
I'll make a motion approve the medical staff report as presented by Dr. Gretchen Whitcomber.
Okay, I have a motion to approve all the changes to manuals along with appointments, forms, environmental services, so on and so forth by Dr. Chalk. Seconded by, is that Sanders? Okay, by Director Sanders, all in favor?
Aye.
Aye. Motion passed. Okay, Finance Committee, Dr. Chalk.
Finance Committee met this afternoon. I defer my report to Mr. Matt Hine, President CEO, Interim CFO.
Thank you, Dr. Chalk. As you all heard, in Finance Committee, we closed out our fiscal year on June 30th. In the month of June, we did exceed our budgeted patient revenue by almost 5%. This allowed us to post a profit from operations before new hospital expenses of $636,000 after depreciation was added in for the new hospital. Our profit from operations was $250,000. We had a great year, and we made a lot of progress in bringing in additional providers, additional specialties. We changed out our emergency room physicians and our hospital medicine physicians. We're seeing a conversion rate that is somewhere far closer to where the national average is for our size facility now over the course of the last 60 days. We do have some big changes ahead of us, and we'll talk about those through HR 1 and the big beautiful bill. We've got a guest here tonight. I'll introduce him shortly. But with everything wrapped up, unaudited at this point, our EBITDA for the year was 17.5%. Accounts receivable gross days ended the year at about 60, and our days cash on hand ended the year at 127. So I think we've positioned ourselves in probably the best possible place to weather some future storms. We will have to be creative in how we do that, but I think that we are in a pretty solid spot financially for an independent rural general acute care community hospital. So that's what I have for you.
Are there any questions of Mr. Hine, our CEO and interim CFO? Wearing two hats today. Hearing no questions, this is an action item, so I need a motion.
So moved.
Motion made by Director Shipman, seconded by Director Krieger. All in favor?
Aye.
Aye. Okay, motion passed. Okay, now we need an approval of FY 2026 budget.
Yep, just for the purpose of the minutes, I won't describe in as much detail as what we just did in Finance Committee, but we are anticipating higher volumes in many categories in FY 26. On the back of those increased volumes, we're anticipating our inpatient revenue is going to be $55 million, or a 7.5% increase over the fiscal year we just completed. Outpatient revenue will be around $200 million, or a 2.51% increase over last fiscal year. Total operating revenue, $254 million, or a 3.56% increase. Deductions from revenue also went up. We're not going to get necessarily paid better. We should get paid more because we are still in a fee-for-service environment. So those went up a little bit, giving us a net patient revenue of $87.3 million, 3.5% increase over FY 25. Total operating expenses came in also higher than what we saw in FY 25. So we're looking at a overall bottom line of $10.8 million profit from operations in our FY26 budget. Um, as mentioned in Finance Committee, this does not have baked in to it the numbers that we're going to talk about shortly on the effects that HR1 will have on our financials. So um, that number will go down based on things that are out of our control through the bill that passed the federal government. So I think those are the highlights. We're going to be busier. We're anticipating greater volumes. I think that we're going to see greater percentage of cash collections on the revenue that we are generating because we have a far more refined revenue cycle now, and we will continue to refine it into the future. Expenses will go up. We've got to give raises. We did already some mid-year raises for radiology technicians and respiratory therapists because we're having a very difficult time recruiting. So we're now more competitive. We're actually very competitive in our market. And then we've got contract negotiations through the union that will take place sometime before the end of the calendar year, and they might spill over into next calendar year, but halfway through our fiscal year. So those are all baked in. All in all, I still think it's a very respectable margin. We will hit all of our debt service coverage ratios. I don't know if we're going to continue to maintain our BB stable rating that we've had for the last couple of years, given the impact of the bill passage. But I do think our story is strong, so there might be a possibility that we'll maintain that. So, anyways, that's those are the budget highlights from Finance Committee, now brought to the board for full approval by the board.
Do we have any questions for Mr. Hunt? Okay, this is an action item. We need a motion.
Make a motion to approve the fiscal year 2026 budget.
We have a motion to approve by Director Krieger, seconded by Director Sanders. All in favor?
Aye.
Motion passed. Okay, we're down to chairperson report here. Just for any of those that may be listening, you have to understand when we talked about the big beautiful bill that we've been receiving matching plus funds from the federal government for a number of years now. And that is what is going to be going away within the big beautiful bill, and we're going to have this gentleman explain that to us in much better terms. But with that being said, I believe that our administration and all of our employees have gone through tremendous acts to try to diversify even further than we have in the past. I see a good increase in our clinic services, which we rely on quite heavily. Our rehab and center has been fairly robust, and although we've had a little bit of a dip, it's fighting its way back. And by diversifying in other areas, we're just increasing our market share. And fortunately, we've been able to do this before we got hit with the deduction of revenues that are coming here in the very near future. It's going to be a scary time, but I do believe that we can weather it if we all stay focused on that goal to do so. And it seems like every year we are faced with another troubling circumstance that we have to weather ourselves through. So we've been able to do it for the last several decades, and I do believe that we still have the fortitude to do that again and continue on. So thank you to our administrative staff and our personnel for continuing on this journey, even though it seems like we're trying to push a boulder uphill. So thank you very much. Okay, with that being said, Mr. Hine.
Okay. I've got just a handful of things to update before we move on to an Impala survey presentation by Jim Cook, and then we'll get to the nitty gritty of the big beautiful bill through a presentation that Ryan has presented or will present, and I'll tag team on at the end with the financial impact to Oak Valley. But before we do that, the eyesore across the street that I don't have to look at as much anymore because I'm not in the building.
You're not
across the
looking
street.
down on it?
I'm not looking down the ambulance facility. We have gone through the process of filing claim with our insurance carrier. They came out, did the full, they did an investigation first. Still no true causation of fire was determined. They just know that it started in that bin. But I have my speculation that how it got started, but no firm evidence to support any of my speculation. So I may as well not even speculate. But what I do know is it was insured um, through our umbrella policy. We'll get about $350,000 in payments from our carrier. It might be a little more than that after we add in everything that got destroyed or burned in that incident. And so we talked with Mattotoni today. You all are very familiar with him, our governance counsel. He's also an expert in municipalities and how we need to go through the process of rebuilding that building. I don't believe that that's the direction we're going to go. I feel like, and Dave Hunter is slated. Dave and I will work together between now and the next board meeting, but he'll present to the board our plan. But just a little foreshadowing, I don't think we're going back in that old building. I think we're going to demo it, and we're going to bring in likely a modular for housing our EMS personnel, far more efficient than what we have had. It'll be laid out the way it needs to be laid out, and they're less expensive than rebuilding, stick build. And we have the vacant lot directly next door to it. So, and then we will look at demoing that old building, or the now burned out building. And we're looking for some possible grants, if there are any out there at this point, to put in some covered solar parking for the ambulance units, because they have to be plugged in continuously in order to keep everything operational. So, and then we'll turn that into ambulance parking and we'll move forward. And so we will follow all the rules that we need to as a public entity. If bids need to be put out, they need to be put out. The opening of the bids at the same time, if we get to that point. But Mattotoni thinks that based on our plan, what I just outlined, if we do go the modular route, everything else can be done under $25,000, which doesn't require a formal bid process through the government entity, public entity that we are.
It does not?
Does not. It's 25,000 or less.
Right.
It does not. And, demoing that building will likely be less than 25,000. Putting a crawl space in for the modular will likely be less than 25,000. Hooking the modular up will likely be less than 25,000. The big expense is going to be the actual purchase of the physical prefab property, which does not have to go out to bid. We just find the best price that has the best suitability for our EMS personnel and purchase it and get it molded. So
How large is it?
I don't know the details of it yet. But we'll present at the next board meeting in greater detail, but I just wanted to let you know that eyesore will be going away, and insurance has agreed to fund up to about $350,000. We are mostly out. Well, we were completely out of the MOB for about a month, and then we decided that it probably makes sense for us to release some clinic space in the MOB on the third floor next to Dr. Mahida's practice. There's clinic space right there. We have the Hera group that has interest in not only seeing patients in the RHC, but in more of a standard medical office space. Central California Surgery, they hit me up very frequently. They want to not only help us in our RHC, which is predominantly Medi-Cal, but they also want to take care of some non-Medi-Cal patients in Oakdale. And so we and they think that that space up there makes the most sense. Dr. Scott has opened up his clinic here in Oakdale. In fact, he bought a home north of town or east of town, and he's has two clinic days right now, David, of a week, 2.5 days a week in our RHC, but also would like to be in that space. And so, and then we're in the process of recruiting some additional PCPs to our community. We've signed all those agreements, done all the all the nice stuff that we're supposed to do in order to sell Oakdale, Cowboy Capital of America, and so world. Sorry, I need to get with the program here. I will start wearing boots to our board meeting. But we are going to bring in additional PCPs. They're going to need space to practice out of, so that will be where they will go. So in our mind, the vision is to have a multi-specialty primary care. Dr. Ariano needs a space to stay also because his lease ballooned up out of control. So, much like we worked with Dr. Horwitz, kind of helped him out in getting, affordable quality leasing, space in our community. We're going to do the same with Dr. Ariano because it's important to keep the providers we already have. And what that organization is doing to jack up the lease amounts is unbelievable. So we're doing our part to try and help everybody out in that process. Of course, lease, we will calculate fair market value for anybody who's going to be subleasing that space from us. So that's very important to do. And they'll pay us a portion based on their time and the square footage that they use. It's gonna all be fine, but it is nice space at the end of the day. And David Rodriguez, how many exam rooms total? 10? 9 exam rooms. So our goal is to pack that puppy up, make it full. So that's our plan. So we were out of the MOB for a month. Now we're back into a tiny portion of it. Going forward, and we got some big plans for that. I will tease this out just a little bit. I think we might be getting close to bringing in a urologist to our community. Dr. Chalk will talk to you about who it is offline, but through some partnerships that we're working on in the Modesto area. So it'd be good to get that, especially here. So anyways, we need a place to house all these, many of these positions, and we think that's the best space because we just don't have any other space. So dialysis, we're still marching forward on that. So David Neal is got all kinds of plans, and we'll have dialysis up and running. If not, the time that the ICU reopens, somewhere in that ballpark. We are still set to open the ICU late October. I've already talked with Mayor Barrios about doing a ribbon cutting for it, another community event, when we reopen the ICU up. She's super excited about it, so we'll do that on a smaller scale than what we did for the new providers, but still good community involvement, I think, is always healthy for a community hospital like ours. So that's coming. Invites will be sent out. And then Soul Radiology, I say the best for last, will take effect September the 19th. So all new radiologists, we will have our new PACS system in place by then, and or close, very close to that time frame. And we're going to bring in additional IR so that we can, in fact, and this is near and dear to me because of a patient a community patient that I work with very closely. We have got to be able to provide diagnostic mammography, um, diagnostic ultrasound work, and if needed, biopsies for breast cancer detection. And we are missing right now the IRPs of that. And so we need to provide that full service to the community. If, heaven forbid, the biopsy comes back positive after pathology reads it, then we will transfer that patient very rapidly to the next appropriate place of care where they want to go for their cancer treatment. But we're too fragmented, and we need to streamline that. And the piece that we're missing right now is interventional radiology. So we'll be bringing more of that on board. And that's what I have as far as general updates on the CEO report, Mr. Chairman.
Okay. Any further questions for Mr. Hunt? No? All right, moving right along. I'd like to introduce Jennifer.
Yes, so Jennifer Cook is here to talk about a survey that took place a couple of weeks ago, and actually just got the results from CMS today, so I'll turn it over to Jen.
As Matt mentioned, an NPEL survey, which stands for the Emergency Treatment and Labor Act, which is a federal law that was enacted to ensure that emergency departments don't turn patients away based on their ability to pay. It also covers obstetrical care in the emergency department, and that typically is their area of focus. So the state is conducted by California Department of Public Health on behalf of CMS. It's a federal survey, so the state comes in, conducts their investigation, puts everything together, and then sends that to CMS, who makes the ultimate determination of whether there is a violation of that law or not. So they showed up on Monday, the 21st, around 2 p.m. Survey took about 4 days. The survey exited on Thursday, the 24th, around 1 p.m. After a brief opening session with myself, Matt, David Neal, and Sean, the ED manager, we were told that the survey was triggered by an anonymous complaint. We didn't get much more information than that. So she did an in-unit survey in the emergency department. She conducted interviews with waiting and registration staff, nursing staff. She observed the nursing care and the waiting and registration areas. We did 22 chart reviews over a broad range of visit types: pediatrics, transfers, surgical cases, obstetrical cases, 5150 holds, just kind of a variety. It seemed apparent to me from the beginning that the focus was on transfers and on surgical cases. So we looked at several of those very early on. The case was identified from January 1st of this year. That was a surgical patient that had a fracture and was treated at O'Fallon Hospital. We spent about an hour looking at that record. There was a few things that she found odd about it, so we spent quite a bit of time looking at that. Also, she wanted to interview the surgeon, the patient, the EMS staff, Matt, and then David Neal. So those interviews were conducted. After the survey spoke with the patient, I can report that he did not file the complaint. He was very happy with his care and was surprised to get a call from the surveyor, but he was happy to speak with her and spoke and said wonderful things about the surgeon and about our facility and the treatment that he received. So that was nice. And then, as Matt stated, we just received notice this morning that there was no findings, so they cleared us of any violation of the survey. So, good news.
Very nice.
Anything else you want to cover?
No, I think that covers it, Jen. Thank you. I know these are long processes for you. You do such a good job. So thank you.
No problem. That's what I'm here for.
Yeah. And a lot more.
Yeah.
Just,
Yeah.
Not just risk management and surveys. So you got a big role. So thank you. Yeah.
Yeah, they
assume to keep adding to your title, Ken. So.
Just letters, right?
Thank you. Okay, now our next information.
Yeah, so for those of you who don't know, our next guest, Ryan, and I'll buzz through these slides as you direct me, but I want to give an introduction first. So I've had the great privilege of working with Ryan for right at 2 years. One of the organizations that we are part of is the District Hospital Leadership Group. And we come together as district hospitals. In fact, our slogan, maybe even our full mission statement, is all for one and one for all. And we totally live by that because there are only 32 of us now in the state. And as you all are aware, we're one of only two that doesn't receive any tax funding for operations. But the group, when we all come together, the leadership of all of these district hospitals, it is pretty powerful. And it is led by Gary as the chairman. He's the CEO of Quia Delta in Visalia, and Ryan and his team. And Ryan came over from the dark side. He was on the Kaiser team for a period of time, but he's got to be one of the most brilliant people I've ever met when it comes to understanding district hospitals, health insurance funding, how to navigate a very complicated system. And it has truly been an extreme pleasure to work with him. In fact, I sent him a text one night a few months ago. I was thinking about how complicated our world is. And I said, I basically just said, thanks for all you do, because we couldn't do it without you. And so I invited Ryan here tonight to talk about HR 1, the one big, beautiful bill. And we're going to talk a little bit about California money first, and then some federal stuff, and then we'll go to the culminating slide that shows the total financial impact this will have on Oak Valley. So with that, Ryan.
Thank you, Matt. Very, very kind. The pleasure is all mine, seriously. And those who do not know, but Matt is an executive committee member of the District Hospital Leadership Forum, so your leadership also helps steer the ship, so thank you for that. We are going to level set just really quickly, because I think before we get to the federal updates, it's important just to kind of take a snapshot of where does California stand in all of this? How are we doing financially? And, this, as a policy wonk and a budget former, I will admit, not only was I at Kaiser before, but I also was a former regulator, worked for the state, leading the finance of the Department of Healthcare Services for Medicaid services for Medi-Cal. So we would always be very fearful of similar tables like this or charts like this that the Legislative Analyst Office would release. But I'll get to that in a second. First things first, in June, just recently, the legislature and the administration came to a final agreement to close a $12 billion budget shortfall. The total budget is $320 billion. Sounds like a lot of money, it really is. But a $12 billion shortfall, largely through temporary solutions, was a huge hole that they had to come to agreement on. Now, the agreement really relied on borrowing money and tapping into some of the similar gimmicks that we've seen in past years. We pretty much tapped all of that out, right? From the legislature's vantage point, they will do everything in their power to not cut services, not roll back benefits, keeping the program as is, with the extent that so long as we cannot run a deficit. The state of California is not like the federal government, right? So it needs to be a balanced budget. So they did everything in their power really to close this monumental task. When you ask the administration points to federal policy impacts, tariffs as a primary driver, rising Medi-Cal costs, and natural disasters that we saw in Los Angeles with the wildfires, etc. But if you look at this out-year snapshot, It shows a state that really is in dire financial circumstances. Those are deficits each and every year, projected deficits between 10, 15, even almost creeping up to $20 billion in deficit if they do nothing today, right? This is the projection. If we were to add columns to the left, 2025, 2026, they just close a $12 billion deficit. If you go back another year, 24, 25, they close another deficit. So this trajectory has been, for the past several years, a reality that the legislature and the administration has had to deal with. The fact that revenues are failing to keep pace with expenditures. Bottom line, as easy as that. And so, from a pressure standpoint, what it does, and the legislative analyst office will always call them out for this, is basically saying they are not in a financial position going forward to take on any new commitments. From the legislature's vantage point, the administration will point to other solutions, and I'll just highlight a couple that were included this year in the budget that they use to kind of close the gap. From a healthcare perspective, if you recall seeing Proposition 35, that ballot initiative that hit the voters enact last year, the allocation of funds were about $1.3 billion that were supposed to be earmarked for Medi-Cal providers through rate increases. The administration did sweep that funding as part of the $12 billion solution. They also have reinstated the Medi-Cal asset limit now for your guys' organization with the distinct partnership facility. That is just another barrier from a access point to Medi-Cal, right? So slow enrollment will likely lead to gaps in coverage on renewals, et cetera. And two other notable aspects that they use to close this gap. One, they've cut specialty drug coverage, specifically the GLP-1 for weight loss. That was a very expensive benefit that was being provided to the Medi-Cal beneficiaries, that they saw that as discretionary from the administration standpoint. But most notably, they made significant changes for the first time to the Medi-Cal undocumented populations, coverage for the Medi-Cal undocumented. Now, these are individuals here who have unsatisfactory immigration status, but have full scope coverage in the eyes of the state. And for the first time in recent history, since the expansions of coverage, they have implemented an enrollment freeze starting in January of next year for ages 19 and over. They have started to add monthly premiums as proposed in the budget of $30 per month starting in July of 27, and they've eliminated dental coverage beginning in July of 26. So these are all, for the first time, part of their out-year solutions that they've tried to kick the can as far as they can, but they're seeing the same writing on the walls, that they have a budget problem, that they need to slow the Medi-Cal costs, and these are some of the low-hanging fruit in their eyes of the first dominoes to fall with how to address this. Now we can shift to the federal piece. What was not included, though, however, in any of these budget conversations was, what do we do with the impending federal changes? So I lay that backdrop in the light of, this was a June budget bill, and then 1 month later, we get the one big beautiful bill, HR 1, that comes with that. All of the $12 billion strategy to close the state problems did not include any of the impacts of this federal change. So what does that mean? We may very well see a special session to address budgetary pressures in this period that they've just closed. But let's get to that setting. So what is the Big Beautiful Bill? The Big Beautiful Bill was a product of budget reconciliation. So in DC, in Washington, D.C., they are allowed to pass with a simple majority through reconciliation, this vehicle that can bypass a lot of the filibustering that happens in the Senate. And instead of doing multiple packages to kind of pursue President Trump's domestic policy agenda, they earmarked it and called it, and frankly, it's labeled in law, this one big beautiful bill, right? And it is really a sweeping federal law that impacts so many areas. I will highlight the healthcare areas, but number one, the priorities were really trying to do their best to extend tax cuts that were expiring this year, as well as increasing the debt ceiling. Because while this does cut $1 trillion in healthcare spending, it also adds to the deficit. The deficit still grows with the output of this bill, which has other effects with Medicare, which we'll get to in a second. But the takeaway for hospitals is in the Medicaid space, there are going to be significant changes, structural changes to eligibility, to enrollment, processes that states have to jump through, to the financing mechanisms. I know it was brought up earlier today about the IGT arrangements that we have in the Medicaid space, the Medi-Cal space. Those all need to adapt to the new world where, while staggered out over multiple years, will have devastating effects to just how we deliver the Medi-Cal program and what that looks like today and the impact of the providers that are providing those services. I have said in DHLF meetings that I do feel like we've hit a high watermark with enrollment in Medi-Cal, with funding, and by virtue of this HR 1, that we are going to start seeing that come down. Enrollment, fewer people enrolled, coverage lapses, which will lead to people falling off coverage. It's going to add a major pressure for the state of California and nationally, not just California, but across the country. Key areas of impact, though, I will say, we've talked a little bit about the financing stuff, but what will really happen is we're going to see cost sharing requirements, work requirements for eligibility. We see new administrative barriers with reducing retroactive coverage, with demonstrating that you are working or volunteering 80 hours a month. You're going to see biannual eligibility redetermination. So for those that are receiving care, they're going to have to demonstrate they still are eligible to Medi-Cal coverage every 6 months. Just more barriers, more hoops to jump through to retain said coverage that they've had, maybe in many cases years at this point. We do see on the financing side limits to provider taxes, so that Prop 35 and the tax, if it were to be passed today, it would not be allowable under the current structure that is in effect with this law. So provider taxes are going to have to significantly change, or they will sunset altogether. Now that is something that will impact all of your private hospital colleagues, neighbors. They do not have access to IDT arrangements like public providers do. As a district hospital has a major benefit. They have to live by different rules and provider taxes, which have we could spend an hour talking about those, but they have completely been overhauled with HR 1 and how in fact that will shrink the available funds for Medicaid supplementals going forward for your private hospital colleagues. Bottom line, it's just going to increase churn. We're going to see higher uninsured rates showing up in your ED, and you're going to have higher rates of uncompensated care. I think that's the bottom line. The impact to your community is definitely going to be felt, and unfortunately, a lot of the gains that we've seen with coverage expansions recently are going to get definitely rolled back in the coming years. On the next slide. So this is not DHLF. This is a variety of folks. So estimated impact for California. So the governor has already come out with his assessment, the department's assessment. They believe 3.4 million of our 15 million today on Medi-Cal will lose coverage. They believe on an annual basis they'll lose $30 billion in federal funding. So the end result, and again, his slide, not ours, costs states billions, close hospitals and clinics. So they fully expect providers to close. Right? There will be, by virtue of these level of reductions, and again, the backdrop of the state's financing picture, they don't have $30 billion to close a federal funding gap, right? So they are fully in a position where they cannot solve this alone. On the California Hospital Association's estimate, so this is statewide, all 450 hospitals, they have estimated it to range between 66 billion and 128 billion. part of that large variance over the 10 years is with or without provider taxes. Again, these are private hospitals they're really focused on too. Without, the situation jumps to 128 billion. With or some modified amount, at best case scenario, they've estimated to be 66 billion. So a 30% reduction in total Medi-Cal revenue from CHA's vantage point. Covered California, right? The ACA marketplace, they believe 30% of their enrollees will drop off coverage, so about 600,000 of the 2 million will drop off coverage, and that those who do stay on without the subsidies, which were also not included in the HR1, that their premiums will increase by 66%. So it is going to have a devastating kind of ripple effect that we're going to see with coverage, et cetera. From a district hospital's perspective, we've looked at this 16 different ways, right? We've looked at it from a coverage expansion, and this is the work that you guys have all done, Chang and Matt and team. But from a statewide perspective, we've looked at all of the different revenue streams with exactly what Matt and Chang have done and the finance teams have done here for what it means for your organization. We've brought that out statewide to the 30 plus district hospitals, and we do see it as about a 30 to 35% reduction in overall net supplementals. So that isn't all at once, and you can see kind of how the phase pain happens here over multiple years. But we do at an annual basis when we get there, when all of the rules that were just changed go into effect, we'll have about 30 to 35% less supplementals than we do today. And that's the high water mark coming down, right? Now, fortunately for us, we, unlike our private hospital colleagues who have tried to get approval from CMS, we did get a recent approval of our 2025 amounts, which really set the bar high before the phase out starts coming down. So we're going to be buoyed up for maybe a year or two by that much higher threshold for funding, but no question, the pain will still come to us, right? We'll still see the reductions in some supplementals over time, and the pain will still come to you all when you see higher levels of uninsured flying through your doors, or challenges with your community. So, but I think this kind of pivots what's on the screen, maybe Matt and Chang, if you guys want to take it from here.
Yeah. So maybe I jumped to the slide a little early.
No,
I wanted this to be like after you finish, we need to talk about how ugly this really is, because you're really nice about it, Ryan. But we have spent as an organization, Chang, myself, in multiple conversations with DHLF, their financing team. What does this really mean exactly for Oak Valley going forward? And so FY26, and we don't have to go through all the IGT numbers. We can go straight to the nuts and bolts of what this is really going to do for us. We're going to go without this fiscal year that we just started. We're going to go without about $3.7 million of funding that we have had historically. And so, the line at the very bottom, it says increase decrease from FY25. So FY25 and previous were our averages as far as what we were receiving for the most part through our supplemental payment programs. And I know we've talked a lot about IGT this and IGT that, but from baseline or high watermark, to use Ryan's terms, this year we're going to go without 3.7. So that budgeted number that we presented of 10.8 suddenly just got shrunk to about 7. And our big beautiful EBITDA that we've had for years, that most recently the last few years is going to get hit pretty significantly. In FY26, we get a little bit of a rebound effect in FY '27. So some of the payments that we're gonna go without in '26, and the biggest one is the HQAF. So, a third of the way down, you can see, there is a number there for FY '25, and then it goes blank. That's what we're gonna end up going without. But you can see the rebound then on the following line in our DHDP payment, or DHDP IGT is gonna go up. And so we do anticipate a little bit of a rebound in FY '27, so it's not so bleak. But then in FY '28, in '29, and '30, and I know a lot can happen between now and then, but it, we start eroding our cash pretty aggressively, our cash reserves, unless we are very nimble and we creatively find new service lines, or bring in additional volume, or whatever the case might be. We will erode our cash reserves and to a relatively dangerous spot when it comes to our debt service ratios. And I don't see that happening until really FY '28, which is a big election year too. But we got some tough times ahead of us. This is a little better forecast when we really got into the details than what we were first talking about at our last board meeting. But it's still not very pretty at all. And so that's a lot of ground to make up when you think about it. Those are pure cash dollars, 3.7 million. So, for us, we collect 33 cents on the dollar. That's like a $10 to $12 million increase in our gross revenue, or gross charges, which is purely volume driven. So it's a lot of work, but I do think, again, we're positioned well, and I think that through our efforts, and Ryan on our last call actually said it, and I don't remember exactly how he said it, Ryan, but it went something like this: that in all of your years of doing this, you find that rural hospitals tend to be the most creative hospitals in finding ways to survive. Because, especially independent hospitals, we are faced with not having deep pockets and being hit time in and time out to make ends meet. And so we'll persevere in some form or fashion. And we're trying to figure that out right now.
I've toured up and down the state, done a lot. I've seen farms before at hospitals. I have seen fishing lodges turned into, affordable housing for staff, etc. I mean, the rural mentality is not one to be messed with. That's for sure. So this reality, though, that is coming, and I commend you guys for at least having this conversation, thinking through 5 years, 6 years down the road is a really important viewpoint to recognize what is coming our way. Does not necessarily take into account a lot of unexpected changes along the way too, right? Which we could see maybe the state still can't maintain their existing obligations, right? Or maybe there's other regulatory actions that are kind of waiting in the wings. We do know that Congress is going to have to be revisiting later this fall with another potential budget reconciliation bill. So did they not go far enough? We don't know yet. So advocacy-wise, and from Matt's vantage point as well, having talked to press, getting the message out there is going to be incredibly critical for us to fend off any more potential threats. So we're not out of the woods yet, is the bottom line. And we know that this pain's just the first quarter.
Yeah, and thanks, Ryan. We haven't talked much about it recently, but there is a seismic compliance thing that's still looming. That's multiples of millions of dollars for our organization to become seismic compliant. There's the Office of Healthcare Affordability that just popped up, and it's now limiting growth on high-cost hospitals. Unfortunately, we didn't make that list. So by golly, we're gonna find ways to grow. But that's a problem. The regulatory red tape that this state has is more than I've ever experienced in my 18 years as hospital CEO in a couple of different states. Whether it's through HCI, just to get our ICU up and running, to get plans approved to stick in their rooftop units so we have proper airflow, is like an act of Congress. And it takes forever. And I know this is being recorded, and that's fine. Yeah, Ryan, you're live streaming right now. So, anyways, there are a lot of challenges that our state has in barriers that they put in front of us. But something's got to give at some point, or we won't be the first hospital to shutter its doors. There's a long laundry list of hospitals that will happen to before it gets to us, and so change has got to come.
We see the first response normally is reduction of service lines, right? You guys have gone through this painfully, right? I was pleasantly hearing that the ICU is reopening, right? That's fantastic. And other parts of the state, see labor delivery services going, especially in rural communities. We see clinic hours getting shortened. We see a lot of, and the responses are not for more access, right, to healthcare services, their less access before closure. So we'll start to see more of that in the immediate future. And then eventually to the governor's estimate, I would also say our estimate as well, there will be fewer hospitals.
And most rural healthcare facilities are in underserved areas anyway. And there are some far worse financial systems that are out there than ours at this time. And you're absolutely right. We've already gone through the reduction of services, and we're trying to add some of those back at this time. So, as I said before, we've made it through for decades, and we'll do it again. I'm fairly confident. Thank you.
Any questions?
I did tell Ryan the group's pretty quiet, so don't expect a whole lot of questions.
No.
He is truly a wealth of knowledge. So
It was a pleasure to be here. Thank you, guys.
Yeah, at what point does the credit card run out for the state?
They're quickly finding that out. Fortunately, we had a ballot initiative a few years back that instituted the rainy day fund. Because before there wasn't really even a massive rainy day fund. But if you go back just a few years, you start to see we had 30 billion in that account. That fund was looking pretty good. By the time the next governor comes in, we'll have liquidated all of it.
Right.
So it may not be this governor's problem. It's definitely going to be the next governor's problem. So.
Thank you.
thank you, Ryan.
All right. Any of our board members have anything to add, or? Super scary. Yes, it is. Okay, well, that brings us to the end of our open session agenda, or regular session agenda. So we would like to entertain a motion to adjourn to closed session. Motion made by Director Sanders,
I'll second.
seconded by Director Shipman. All in favor?
Right.
Aye. Okay, we're adjourned.